Although social acceptance of the LGBT community is improving, individuals continue to experience discrimination and stigmatization that perpetuates health disparities. The LGBT population has historically been neglected and left with inadequate resources and a lack of access to informed and inclusive healthcare. When discrimination is extended into healthcare settings, members of the LGBT community will avoid seeking healthcare, reducing opportunity for preventative action, further exacerbating health disparities of the community. There is an urgent need to provide high-quality, informed, and inclusive healthcare to LGBT individuals of all demographics to diminish health disparities. According to data from the largest study of transgender and non-gender conforming people in the United States, 19% of participants reported refusal of medical care, especially among people of color. 50% of participants reporting having to teach their healthcare provider about transgender care. 28% reported avoiding medical care due to discrimination. 48% reported avoiding medical care due to inability to afford it. And 56% of LGBTQ individuals reported experiencing discrimination while seeking healthcare. This report is a call to action for healthcare providers to take responsibility for LGBT patient care to confront patterns of abuse and injustice. In addition to avoiding or being denied healthcare, the LGBT community faces numerous health disparities that can be prevented. LGBT individuals have the highest rates of drug, alcohol, and tobacco use. Youth are 2 to 3 times more likely to commit suicide and experience homelessness. The aging population has difficulty finding competent medical providers and often have their identity erased. Lesbians are less likely to seek preventative care for cancer, especially for cervical cancer. Lesbians and bisexual women are more likely to be overweight and obese. Gay and bisexual men make up 4% of the U.S. population, yet account for 61% of annual HIV infections. Transgender individuals experience high rates of violence, victimization, mental health issues, and suicide. The term homosexuality was removed from the Diagnostic and Statistical Manual of Mental Disorders in 1987. Queer people have been subjected to the horrors of conversion therapy that use cruel tactics in an attempt to erase one's identity. The scars of decades of identity rejection, shame, and punishment are detrimental, and healthcare providers must become a catalyst to the healing process. LGBT individuals have an increased risk of anxiety disorders, PTSD, substance use, body dysmorphic disorder, eating disorders, and personality disorders. The minority stress theory suggests that, for LGBT people, repeated difficult social situations constitute stressors that contribute to health disparities. The LGBT population faces unsafe social situations, prejudice, discrimination, and familial rejection that fuels poor mental health and decreases opportunity and access to healthcare. Continuous research shows that people are more likely to experience poor mental health when they are isolated or disconnected from relationships. LGBT people are often denied and punished for seeking and maintaining intimate relationships. It may be difficult to find a supportive community and make meaningful friendships, making the likelihood of developing mental disorders quite high. Evidence does not support the notion that LGBT individuals are inherently susceptible to health problems. Mental health is often a response to a cascade of instabilities. According to the LGBT Homeless Youth Provider Survey, 40% of clients, homeless and non-homeless, are LGBT individuals. 30% utilize emergency shelters, transition living programs, and other housing-related services. 68% reported that family rejection was the biggest factor contributing to homelessness. Health providers must be attentive to the risk factors associated with poor mental health and create a welcoming, safe environment to promote trust and disclosure. Providers should screen thoroughly for conditions that pose an increased risk for members of this population. Familiarizing yourself with the correct and appropriate terminology and use respectful language is critical. For example, asking, "What name would you like me to use?" and "What are your pronouns?" These questions can be asked on paperwork prior to the visit to avoid assumptions and to show that the environment is safe. Cardiovascular health is crucial to test in LGBT patients because they may have a higher risk factor due to the increased prevalence of smoking, anxiety, depression, substance use, and obesity. Screening for obesity, cholesterol, lipids, and blood sugar are essential to test for the general population, and additional screening should be based on an individual's specific risk factors. The Center of Excellence for Transgender Health at the University of San Francisco states that screening for blood pressure, cholesterol, and lipids should be consistently monitored for transgender patients before, during, and after hormone therapy. Studies reflect that women who have sex with women are disproportionately represented among groups of individuals that infrequently or avoid screening for cervical cancer. Unfortunately, it is likely due to a failure of the patient or the provider to understand that women who have sex with women are also at risk for cervical cancer. Transmission of HPV between women is possible, and there is a higher rate of transmission among smokers and sexual minority women, a known risk factor for HPV. Reduction of screening can be due to patient discomfort with the practitioner or the exam itself. Screening for cervical cancer among transgender patients must be conducted according to the organs present at the time, but it is essential that this is approached with sensitivity, respect, and integrity. Ask appropriate questions to know if it's necessary to screen for pregnancy. Patients with breasts should have routine examinations according to their age as well as hormone monitoring. Medical examination often frustrates transgender patients due to anticipated discrimination, disrespect, humiliation, denial of care, and can contribute to body dysphoria. Body dysphoria is a disorder that is characterized by an obsessive analysis or chronic dissatisfaction of one's body or appearance. This is common among transgender patients when it is reminded that their organs do not align with their identity, which can lead to confusion and dissatisfaction with the self and dissociation of the body. To create a safe atmosphere that builds trust, practitioners must ask and abide to appropriate pronouns and terminology. The forms that patients fill before a visit should ask female, male, transgender, or other to avoid gender assumptions. Body parts should be referred to as gender-neutral organs such as words like chest and genitals or person with a vagina to increase the patient's trust and comfort levels. Questions about genitals should only be applied when appropriate, for example, not for a visit for bronchitis.
I would want a provider to ask me how I identify my gender, how I identify my sexuality, how do I feel in my body, which is really important because a lot of times I feel very dysphoric and doctors will go to grab me and I am not a touchy-feely type of person, and so that feels invasive. So preparing me for whatever they need to do in order to figure out what's going on for me, I feel like especially because they are speeding through, there's not a lot of how can we trust each other, get comfortable with each other. I mean, you know, being in a doctor's office is, I guess, to me, is a very, I mean, we're taking off clothes and the doctor is not my partner, the doctor is not me or my mother or my parents, so it's a very vulnerable place to be. And so the relationship to me has to be affirming and understanding. And so if I'm going to disrobe in front of you, I don't want to get funny looks. I don't want to get, you know, any of your negativity towards me because this is a very, very vulnerable space. And so it's really important that you adjust your own self before working with me.
One thing I would really like providers to ask me is my reproductive desires, and I don't think it necessarily comes up because there tends to be an assumption that if you're trans, you don't necessarily want to have kids, and I don't think that's true. Like, I would love to have children, but it's never been asked, and especially just having the discussion prior to initiating any type of like hormone use, I think is really important, and just assessing, you know, what are your options prior to what are your options later in life. I think that one was really important for me, and it wasn't discussed.
Having a provider that understands trauma, that is trauma-informed and also seeks consent throughout the process, that was very important to me. And so it was a lot of little things that made it a positive experience for me, of just constantly checking in because, you know, I hadn't had a PAP in a while. So asking me, is this okay? This is what I'm going to do. So informing me of each step so that I wasn't surprised and making sure that I was comfortable throughout.
What I'd really like providers to know about my sexual health needs is that I do want to discuss them, even if it may be somewhat uncomfortable for me to do so. There's a lot of history tied in with being trans and with body discomfort, and even if I'm not very open about it, it's not because I don't want to discuss.
Men who have sex with men make up roughly 4% of the US population, yet account for 61% of new HIV cases per year. However, gay men with HIV is highly stigmatized with harmful stereotypes. It is indeed a problem but must be approached with respect and without assumptions. Pre-exposure prophylaxis, also known as PrEP, is an antiretroviral taken in advance of sexual exposure and to be used alongside with the use of condoms and safe sex counseling for preventative measure. HIV should not be generalized. Men have dynamic identities and other risk factors that should be screened to promote men's health. Compared to heterosexual men, gay and bisexual men have an increased risk of self-harm, suicide, eating disorders, drug abuse, tobacco, panic attacks, and depression. Men who have sex with men are also at risk for anal cancer. Risk increases when exposed to HPV, many sex partners, unprotected sex, HIV, and tobacco use. Men may avoid screenings due to fear of stigmatization.
I think we need to act, and we need to act now.
Because the reality is, we're not where we want to be. I mean, this should be like a national sort of effort.
It's no longer about intervention. For me, it's about how do we implement what we already know where it needs to be implemented.
And the interventions can no longer focus solely on the person who's experiencing the problem.
Prevention or changing adherence is not going to be a one-time activity. It's something that's going to have to occur in an ongoing and sustained fashion.
Again, we're talking about this multi-level necessity if we're going to end this epidemic now.
It's not a day, it should be a movement. And until we have that movement, we're not going to be doing the work that I think we need to be doing.
The article LGBT Healthcare Disparities, What Progress Have We Made? Examines 590 healthcare facilities to assess the current state of LGBT health and where improvements must be made. In a survey of LGBT physicians, 65% reported hearing derogatory language from healthcare professionals about LGBT patients. Another survey found that 72% of nursing educators from accredited colleges reported feeling unprepared to teach LGBT-specific healthcare. Nearly 80% of nurses had not received LGBT-specific training. This concludes that there must be more practitioner education of LGBT-specific health and research conducted on the healthcare disparities of this vulnerable population in order to provide effective preventative treatment.